This podcast is specially produced by the Critical Care Education Foundation's Knowledge Hub Project for You, with the intention of providing a learning opportunity for doctors. It supplements the other material and self-assessments available on the CCEF Knowledge Hub project.
Welcome to this deep dive. Today, we're tackling a really critical topic, one of the most profound in intensive care, actually, brain death, or as it's also known, death by neurologic criteria.
That's right.
And it's not just a definition, is it? It's this huge moment for patients, families, and, well, crucially for you, the medical professionals managing care.
Absolutely.
So our goal today is to give you a clear, structured way to understand how it's determined and, importantly, the really meticulous management needed right there in the ICU.
And it's fascinating because brain death, or DNC,
Yeah.
it's legally and medically the same thing as circulatory death. Complete equivalence.
Which means the precision.
Yeah.
It has to be spot on. Exactly. Precision in determination, and then in the management that follows, it's paramount. We'll be pulling from solid guidelines, recent updates to make sure the approach is standardized, evidence-based, and really highlights the ICU team's critical role.
Okay, let's get into it. What exactly is brain death in practical terms, and why is understanding its prevalence, how often we see it, so important in the ICU?
Well, fundamentally, brain death means the irreversible end of all brain function. And that absolutely includes the brainstem. It's total cessation.
Not just the higher functions.
No, everything. And thinking about the bigger picture, it causes maybe 1% to 2% of all deaths in, say, advanced healthcare systems. But for us in the ICU, it's much more significant.
Right.
It counts for maybe 5% to 10% of deaths among comatose patients we manage. Interestingly, though, and this is a positive thing, the incidence seems to be decreasing slightly, probably due to better trauma care, better prevention, which is, good news.
That is good news. A declining trend is definitely encouraging. So what are the main reasons, the primary causes, that lead a patient to this point in the ICU?
The big one is severe traumatic brain injury, TBI. That accounts for, maybe 40% to 50% of cases.
Almost half.
Yeah, it's significant. Then you have intracranial hemorrhage, like strokes or bleeds. That's maybe 25% to 30%.
Okay.
After that, hypoxic ischemic encephalopathy. So brain damage from lack of oxygen, often after cardiac arrest, that's about 15% to 20%.
Right.
And the rest, maybe 5% to 10%, is cerebral edema from various other causes. Knowing these helps the ICU team identify patients who might be heading towards this.
It helps focus the evaluation.
Precisely, for timely and careful evaluation.
Okay, so let's say the clinical picture strongly suggests brain death. How does the ICU team actually determine? It's not just one test, right?
Definitely not. It's a really rigorous, very structured process, 3 sequential steps. It demands absolute meticulousness from everyone involved.
3 steps. What are they?
First, you establish the essential preconditions. Second, you have to painstakingly rule out any reversible cause that could be mimicking brain death.
That sounds crucial.
It is. And third, you confirm it with the clinical exam, assessing brainstem reflexia and performing the apnea test.
And all 3 steps are equally important. No cutting corners.
No, absolutely not. Each one builds on the last. They're all vital for diagnostic accuracy. We cannot afford a misdiagnosis here.
Understood. Let's break down that first step,
Yeah.
the preconditions, what absolutely has to be in place before you even start the formal testing, the non-negotiables.
Right. First, you need clear, unequivocal evidence of irreversible brain damage. And it has to come from a known cause, a known etiology.
Okay.
And not just any brain damage. It has to be catastrophic, involving both cerebral hemispheres and the brainstem. Imaging, like a CT or MRI, is essential to confirm the severity.
So you need that visual proof too.
Yes. Then, physiologically, things need to be stable, optimized by the ICU team. Core temperature needs to be above 36.5 Celsius.
That was recently updated, wasn't it, from 36?
It was, yeah. Because even mild hypothermia can really impair consciousness, mess with reflexes. So 36.5 or higher.
Got it. What else?
Blood pressure needs to be stable. Systolic above 100 or a MAP above 65. Might need pressors for that. Oxygenation needs to be good SpO2 over 95%. And no severe acid-base issues clouding the picture.
all stable before testing begins.
Well, it's B, optimize before starting any formal exam.
And how long do you need to observe the patient to be sure it's truly irreversible before starting that process?
Yeah, the observation period is critical. It depends on the injury type. For standard things like a bad TBI, minimum 6 hours post-injury.
6 hours.
But for hypoxic ischemic injury, like after cardiac arrest, the damage evolves slower. So it's a minimum of 24 hours.
Much longer.
Yes. And this is really important. If you suspect drug overdose might be contributing to the coma,
Ah, yes.
the ICU team must wait for at least 5 half-lives of whatever the longest-acting drug was to make sure it's completely cleared. No lingering drug effects mimicking brain death. Diligence here is key.
Okay, step 2 then. Excluding those reversible causes. This seems like where you could really make a mistake if you're not careful.
Yeah.
What common things does the ICU team need to rule out?
This is where meticulous clinical judgment is absolutely vital, and the whole team's vigilance. You have to be sure the patient isn't still affected by sedatives or painkillers.
Like propofol or midazolam.
Exactly. Propofol effects can last, 4 to 12 hours. Midazolam, fentanyl, easily 12 to 24 hours, sometimes longer depending on the patient.
So you might need to wait quite a while after stopping them.
You do. Or, in some cases, you might consider reversal agents. Flumazenil for benzos, naloxone for opioids, but carefully.
Okay, what else?
Neuromuscular blockade, paralytics, must be completely gone. We checked that with a train of 4 stimulator.
The TOF test.
Yeah, looking for 4 out of 4 twitches. Plus, checking deep tendon reflexes. If they were on rocuronium or vecuronium, Sugamadex is the reversal agent you'd use.
Got it. No paralysis masking anything.
None. And then, don't forget metabolic issues. They can really mimic brain death sometimes.
Like electrolytes.
Absolutely. The team needs to normalize key electrolytes. Sodium between 120 and 160. Glucose, ideally 150 to 200. Phosphate above 2.5. Magnesium above 1.8.
A lot to manage.
It is. And check endocrine function too, if needed. Thyroid, adrenal status, especially if they're hypotensive. And look for loss of temperature control. That poikilothermia often happens in brain death.
Okay, so preconditions met, reversible causes excluded. Now for step 3, the confirmation. Testing the brain's responses directly. What reflexes are you looking for?
Right. This is the clinical examination, a systematic check of cranial nerves looking for a complete absence of response.
Okay, which ones specifically?
First, pupillary light reflex. Shine a bright light. No reaction in either pupil, that's one sign. Size doesn't matter, just reactivity.
No reaction. Check.
Then, corneal reflex. Touch the cornea gently with a cotton wisp. Should be no blink.
No blink? Okay.
Third, the oculovestibular reflex. The cold caloric test. Assuming the eardrum's intact and no wax, head up 30 degrees if the C-spine's clear. And still 50 milliliters of ice water in the ear. Wait 5 minutes. Normally, eyes drift towards the cold.
Yeah.
In brain death, no eye movement at all.
None.
Fourth, oculocephalic reflex. Doll's eyes. Again, C-spine must be clear. Turn the head rapidly side to side. Normally, eyes move opposite the head. In brain death, they move rigidly with the head.
Like a doll's eyes, literally.
Exactly. Then, facial pain response. Press firmly on the supraorbital notch or the TMJ. No grimace, no withdrawal.
Nothing.
And finally, the gag reflex stimulate the back of the throat and the cough reflex deep suction down the ET tube. Both must be completely absent. The ICU team performs these very carefully, often with 2 physicians confirming.
A very thorough checklist.
Yeah.
And then the apnea test. This sounds like the most critical, maybe riskiest part.
It is critical, and yes, it carries risks, which is why safety is paramount. The updated guidelines really stress this for the ICU team.
So how do you prepare?
Meticulous prep. First, pre-oxygenate really well. 100% IO2 for a full 15 minutes. That's longer than before. Helps build oxygen reserves.
Okay, 15 minutes.
Then, get a baseline arterial blood gas and ABG. You need the starting PASHA-2 between 35 and 45 and pH normal 7.35 to 7.45. And keep the patient hemodynamically stable systolic over 100.
Prep done. What's the procedure?
Carefully disconnect the ventilator. Then provide oxygen down the breathing tube, usually via a catheter, 5 to 6 liters per minute, and then you watch. Observe closely for 5 to 10 minutes for any sign of breathing effort.
Watching for any chest rise, anything.
Anything at all. The test is positive, confirming apnea. The PASHA-2 rises above 60 mmHg, or R, it goes up by more than 20 mmHg from the baseline, and the pH drops below 7.30, with absolutely zero respiratory effort seen.
So, a significant CO2 rise and acidosis with no breathing.
Correct. But crucially, there are strict abort criteria. You stop immediately and reconnect the vent if the blood pressure drops below 90 systolic, or O2 sats fall below 85%, or if serious heart rhythms occur.
Safety first.
Always. These protocols minimize risks during this essential diagnostic step. It reflects the team's commitment to safety even here.
Okay, so that determination process is incredibly rigorous. Once brain death is formally declared, what's next?
The focus shifts entirely, right? How does the ICU team manage the patient then?
It shifts completely, yes.
Yeah.
Once determination is done, the focus is all about meticulous physiological management. And you might ask, why continue this intensive management?
Yeah, why?
It's absolutely vital, especially if organ donation is a possibility. Optimal physiological support by the ICU team directly impacts organ viability. It can make the difference between successful transplantation or not. The goal changes from saving the brain to saving the organs.
Makes sense. Let's start with hemodynamics then. What are the goals for the ICU team?
Stabilizing hemodynamics is priority 1 for organ preservation. The team needs to be aggressive with fluid resuscitation, often using 5% albumin or crystalloids. We're targeting specific numbers,
Right.
systolic pressure between 100 and 140, and maybe 65 to 85, CVP if you're measuring it 8 to 12, and good urine output, over 1 millivol per kilo per hour.
And if fluids aren't enough, pressors. Yes. Vasopressor protocol usually starts with norepinephrine. If you need high doses, say over 0.5 mics per kilo per minute, then you add vasopressin, typically 0.5 to 2 units an hour.
Okay.
And if you identify low cardiac output, which isn't uncommon after brain death, add dobutamine, maybe 2.5 to 10 mics per kilo per minute to boost heart function.
Right, and I know hormone replacement therapy, HRT, is a big part of this too.
It's critical. For stability and organ preservation, the updated protocols your ICU team should follow include methylprednisolone, a steroid, big dose up front, 15 milligrams, then an infusion. But here's a key update.
What's that?
There's now a new 12-hour taper of the steroid before organ recovery happens. Important detail.
Okay, noted. Steroids. What else?
Thyroid hormone, levothyroxine or leotheranine. Insulin is crucial too. Keep glucose between 150 and 200. Hyperglycemia is bad for organs. And vasopressin is part of this hormone cocktail as well. But another critical point, stop it 2 to 4 hours before organ recovery.
Why stop the vasopressin?
To allow for proper assessment of kidney function and vasopressor needs during the recovery itself. These updated HRT protocols, they can improve organ viability by 15 to 25%. It's a huge impact.
Wow, that's significant.
Yeah.
Okay, beyond hemodynamics, what about managing the lungs? Especially if they might be donated.
Equally critical. We use strict lung protect ventilation strategies. Tidal volumes kept low, 6 to 8 millibelts per kilo of predicted body weight. PEEP needs to be adequate, usually 8 to 12 centimeter H2O.
Preventing lung injury.
Exactly. Keep plateau pressures below 28. And there's a new target now. Driving pressure less than 15 centimeter H2O. That's the difference between plateau and PEEP, another measure of lung stress.
Driving pressure less than 15. Okay.
Plus, routine suctioning, good positioning, all standard critical care, but especially vital here. These strategies can boost successful lung transplants by 20 to 30%. The ICU team's vent management is truly life-saving in a different way here.
Diabetes insipidus, DI. That often happens after brain death, right?
Yeah.
How does the ICU team handle that massive urine output?
Very common, yeah. Loss of ADH from the pituitary, diagnosing it. Urine output rockets, over 4 mK/hour, maybe over 300 an hour total. Urine is very dilute specific gravity, less than 1.005. And sodium often climbs high, over 150.
So how do you treat it?
Immediately replace that urine output ml for ml with hypotonic fluid, usually half normal saline, 0.45%, or D5W. And give desmopressin, DDA EVP, start with an IV bolus, maybe 0.3 micrograms, then give 0.3 to 1 microgram IV every 6 to 8 hours. You have to titrate it carefully based on urine output and sodium.
Titration is key.
Absolutely. A continuous vasopressin infusion is another good option instead of DDA EVP.
Okay. And what about other electrolytes? And coagulopathy, that can be an issue too?
Big issues. The ICU team needs rigorous electrolyte management. Correcting that high sodium, do it slowly. Target less than 10 points drop per 24 hours to avoid brain swelling issues. Keep potassium, magnesium, phosphate, calcium all in range with protocols.
And the coagulation part?
Monitor labs frequently every 4-6 hours. PT-INR, PTT, fibrinogen, platelets, D-dimer. What's relatively new is recommending ROTEM or TEG thermal elastography if you have it.
Those give a fuller picture of clotting.
Exactly, a real-time functional picture. Intervention thresholds are clearer now too. Transfuse platelets if they're below, say, 75,000. Replace fibrinogen if it's under 200.
Okay.
And you have protocols for packed red cells, keep hemoglobin 8 to 10, plus FFP, cryoprecipitate. Fibrinogen concentrate is another tool we use more now. It's a constant balancing act for the ICU team.
It really sounds like it. Now, what if the clinical exam isn't enough? Maybe severe facial trauma makes testing reflexes impossible. What ancillary tests can confirm brain death?
Good question. Ancillary tests are your backup. Used when the clinical exam is incomplete, or maybe confounding factors are present, or sometimes just for legal reasons or family reassurance. They objectively show lack of blood flow or electrical activity.
What are the main ones?
First-line options. CT angiography, CTA, is very common, widely available, sensitive. The team looks for no blood flow past specific points in the carotid and vertebral arteries inside the skull.
Okay, CTA. What else?
Transcranial Doppler, TCD. That's bedside, non-invasive ultrasound. It shows specific patterns like little systolic spikes, back and forth flow, or just no flow signals at all, even though the heart's beating. It's highly specific, about 98%.
TCD is convenient being bedside.
It is. If those aren't conclusive, you move to second-line tests. Nuclear medicine scans like TC99-METO HMPAO SPECT show an empty skull, no perfusion uptake. And the absolute gold standard, if needed, is conventional angiography, though it's invasive.
So several options depending on the situation.
Right. The ICU team coordinates getting the right test done.
Are there special situations, like patients on ECMO or kids? Do the protocols change? How does the ICU team adapt?
Yeah, great point. You have to adapt. For ECMO patients, that apnea test is tricky because the machine handles gas exchange. So the team might need to reduce the ECMO sweep gas flow or even add CO2 into the circuit to let the patient's own CO2 rise and see if it triggers breathing. Often, though, ancillary tests like TCD or CTA are preferred on ECMO.
Makes sense. What about children?
Pediatrics criteria are pretty similar for kids over 2 months old, but the observation periods are longer depending on age, sometimes 24 or even 48 hours for infants. And the PathO2 target for their apnea test is a bit higher, maybe over 65 or 70.
Higher CO2 target. Okay. Any other specific cases?
High cervical spine injury. You absolutely cannot do the doll's eyes maneuver, the oculocephalic test, too dangerous, so you rely more heavily on other reflexes and ancillary tests. And we even developed specific protocols during COVID-19.
Oh, interesting. How so?
Longer observation periods if the brain injury was hypoxic, sometimes 48, 72 hours, and often preferring CTA over TCD because lung issues could interfere with the Doppler signals, always adapting.
Constant adaptation. It sounds like this whole process requires incredible coordination and quality control. How is that ensured? And what about the rest of the team, beyond the doctors?
Quality is key. Standardized metrics help track performance. Things like, how quickly is the brain death evaluation initiated after criteria are met? Aim for under 6 hours. Is the documentation complete and accurate? Target over 95%. And, very importantly, family communication, are their needs being met? Aim for over 90% satisfaction.
Measuring the process.
Exactly. And the multidisciplinary team is vital, not just doctors. Early notification of the Organ Procurement Organization, the OPO, is crucial.
Even before the family decides on donation.
Yes, regardless of initial wishes, it allows the OPO to be ready and ensures optimal organ preservation support is initiated if donation becomes the path forward. Social workers, chaplains, ethics committees, they provide immense support to families during this incredibly tough time.
A whole network of support.
Absolutely. And avoiding pitfalls is part of quality, too. Things like not waiting long enough for drug clearance, testing when the patient is still cold, doing the apnea test incorrectly. A cohesive team approach with early OPO input really does improve outcomes. Multidisciplinary rounds are key.
So, critical care is always evolving. What are the latest updates or future directions in brain death determination and management that ICU teams should be aware of?
There have been some significant updates recently. The big one was the Unified ANNAAP guidelines in October 2023, merging pediatric and adult approaches. Big focus on enhancing apnea test safety, too.
The unified guidelines, right?
And the World Brain Death Project in 2020 set minimum global standards, really emphasizing a conservative approach to avoid any chance of a false positive.
Standardization and safety makes sense. What about new tech?
The future looks interesting. AI is starting to help analyze CT and MRI scans, showing really high agreement with expert readings, potentially speeding things up. Automated documentation using AI could also cut down errors and free up team time.
AI assistance.
Yeah. And predictive analytics might help identify patients heading towards brain death earlier. Plus, advanced monitoring is getting better continuous EEG, near-infrared spectroscopy to monitor brain oxygen directly, multimodal monitoring combining different data streams.
Real-time brain monitoring.
Exactly. All aimed at improving transplant outcomes and making the determination process even more precise and efficient for the ICU team.
This has been incredibly insightful. We've really gone deep into the layers of brain death determination, the meticulous ICU management, the teamwork involved, and even future directions. You should now have a really solid overview of this critical area.
It's complex, isn't it? Understanding brain death isn't just about knowing the criteria. It's about navigating this profound moment with skill, precision, but also immense compassion. And it leads to that important question for all of us in critical care. How do we keep getting better? Better technically, yes, but also better humanistically. How do we ensure we handle these incredibly challenging situations with the utmost care, clarity, and support for everyone involved, the patient, the family, and the team?
A crucial question indeed. We hope this deep dive has been a valuable learning opportunity for you. Remember, you can find more resources and self-assessments on the CCF Knowledge Hub project. Stay curious, stay informed, and we'll see you on the next deep dive.